All right, good morning, everyone. Like Chimeng said, my name is Fotis. I'm one of the Echo Fellows, and I will go through a couple of interesting for me, it's to be seen, but interesting for everybody else, about the physics of ultrasonography, as well as a little bit of real-world examples of how we can use math and physics to help our day-to-day lives. Some of you may have heard this talk. It's been updated a little bit. Those who have not heard this talk before, I recommend that you take a listen, especially because this is a shout out to all my C1s out there who need to kind of get a better sense of what we're really actually talking about. And I think the best way to do anything like that is from first principles. So without further ado, let's talk a little bit about the physics of echocardiography. So I'm hoping to make this fun. So this is going to be Fotis's fun physics. There's also a nice little alliteration there. And so what we're going to try to do is we're going to try to learn some of the basic concepts of creating ultrasound waves, or what an ultrasound wave is, and then discuss the physics behind those sound waves and how we can manipulate the physics, not manipulate, but exploit the physics to kind of understand what we're looking at. And then we're going to use a real world example about aortic stenosis, which is a very common valvular lesion in cardiology. And it actually uses a lot of the principles that we're kind of discussing. And we're going to build slowly the foundation. So a caveat here is that there's no good place to start, so I'm just going to start. And then there might be concepts that people aren't familiar with, but I'm going to try to build those concepts slowly so that we culminate to some bigger picture. So making waves. So this is a wave, and this is what this is the fundamental principle behind everything that we're doing, is we're using the properties of waves to exploit certain physical characteristics, both of the body and of the machine that's actually reading these ultrasound waves. Some of the important things to think about are amplitude. So we talk about amplitude of a wave. So that's the height from the trough to the peak. Then you have one full cycle. So a cycle is the same as a wavelength. And that wavelength is going to be described as basically from one certain point of a wave to the next exact same point of a wave. And this is actually one wavelength away. What's interesting is that, ultrasound, not ultrasound, but any wave that propagates through space is actually propagating through stuff. And so the stuff that it's propagating through, the urban sounds of the city are behind us. So the stuff that it propagates through mostly, like what I'm doing right now, is air, right? And so in fact, it's not only just this undulation that we've expressed as a line that kind of goes up and down, but it's also a little bit about the compression and rarefication of the medium in which it's in. For example, in air, when I start to talk, there are going to be areas where there's more air, so it's more compressed, and there's going to be areas that there's less air, which is less compressed. And those are, in fact, how we modulate our speech by changing essentially the frequency and wavelength, which changes the air pressure, which hits our eardrum, then gets turned into kind of an electrobiochemical force, which our brain figures out as sound. So that's kind of a neat way to think about it. So we have this wave. Let's kind of define a little bit of some of the characteristics. So the speed of sound wave in a given medium is going to be defined by the medium itself. So like I said, if air is the medium, there's a speed of sound there. If the body is a medium, there's a speed of sound there. And then the speed of sound in that area, oops, I don't know what just happened there. The speed of sound in that area is going to be 1,540 meters per second. And importantly, we have to understand that one of the basic principles of waves, if you can remember back into physics, is that there is a relationship between frequency and wavelength. And so for our purposes, our wavelength, lambda, is going to be defined by this constant, c, which is the medium through space, 1,540 meters per second, divided by the frequency. The number itself isn't as relevant as the fact that we start to derive a concept where wavelength and frequency are inversely related. And that's important, all right? There's a fixed attenuation between wavelength and frequency, and that has to do with the medium that the sound wave is going through. But in general, the relationship is inverse. So those of you who are still awake and are thinking about this, you can ask, so why do we care? Well, I think that's a really good question, because it brings us to the concept of spatial resolution. And spatial resolution is the ability to distinguish 2 points in space. And this is directly related to wavelength. And I'm going to illustrate this perhaps ad nauseum so that we can understand what it is. But I think it's important because we think about spatial resolution as how we can distinguish two structures, and in our case, in an echo, is two structures within the heart. And sometimes we have to think about the wavelengths that we're giving to make that happen. And in fact, there's two types of spatial resolutions. There's something called axial resolution, which is kind of a longitudinal resolution. So on the same line, can you distinguish 2 points? And then there's lateral spatial resolution. And that's if you can distinguish 2 discrete points that are next to each other, but are perpendicular to the ultrasound beam. So these are some pictures to describe that. So on the left, we have axial resolution, which is something that can be used in ultrasonography, but it's more about the lateral resolution. But let's start with axial resolution because I think it's a good example. So you have a transducer A and you have a transducer B. On the left in transducer A, the wavelength, actually, you know what, let me step back. The frequency of these waves, okay, in transducer A is higher than the frequency in transducer B. And what I mean by that is that there are more peaks and more wavelengths, all right, associated with that on the left, transducer A, than in transducer B. And in fact, the wavelength, as you can see compared to them, is shorter. So if you go from one peak to the next on transducer A, that distance is shorter than the peak to peak on B. And that is kind of a really good pictorial representation of the inverse relationship between frequency and wavelength. So then transducer A sends a signal at a wavelength at a specific frequency that's high. And what it's able to do is you can see the little dots that are present on the side of the side here. And you can show you that this dot and this dot are correlating to specific points on the wavelength. And in fact, these dots are able to understand the difference between structure A and structure B. In contrast, on the right, transducer B has a lower frequency, a higher wavelength, and it, in fact, in one cycle, will see both A and B. So transducer A will show the images A and B as separate objects, and transducer B will show objects A and B as the same object. All right, so that's how it's important to understand the inverse relationship between wavelength and frequency. Now, something more kind of understandable from our perspective is talking about the lateral resolution. So as you can see, there are certain fans of beams that are coming down from this transducer. And the closer you are to this transducer, the more those two dots on A intersect different planes. And that's the ability for the machine to figure out that there are two separate dots. Whereas the two same dots, which are further from the transducer, but within that same fan or that same triangle, are now going to look like one object instead of two objects. And that's the principle whereby we have lateral resolutions. The difference between understanding if this is the RV free wall or the LV septum, RV septum and LV septum is going to be defined by our lateral resolution, our ability to pick up two side-by-side differences. And so this is kind of the pictorial representation of the exact same thing. We both have a lateral resolution and an axial resolution, but in this case we have it with a lovely picture of an ultrasound beam, and it's the same principle. The closer you are to the transducer, the more lines are stacked together, the higher ability to be able to have good lateral resolution. And similarly for axial resolution, it's going to be the same along the entire axis. Doesn't matter how far it is from the transducer, but it's going to be dictated specifically by the frequency, because if you have one wavelength that captures both of those green dots, they'll look like one. And if you have a wavelength that's going to split those two green dots, you'll have two. Similarly, and as said ad nauseum, I would explain the differences. But in this case, it's actually kind of an interesting concept, which we're not going to get into, but for those who are interested, there are some primary determinants of how these resolutions happen. So for example, in axial resolution, we said it's related to the frequency and the length of the pulse. And in the lateral resolution, it's actually going to be the beam width, the depth, and the gain, which is important because we use a lot of those concepts when we're doing ultrasound day to day. And so, the biggest issue that we have is how we're going to exploit some of those waves in the heart. And what it turns out is that the highest amount of reflection of ultrasound waves happens between the interface of two structures. Now, for those of you who are C1s who are currently not at St. Mike's, I don't know if they're writing on this call, this is a big hint to a quiz that is absolutely random, but entirely mandatory when you come into our rotation. And so you can also see that this cartoon representation is that the brightness between the two interfaces is what we're going to see the most. So there's an interface between the epicardium and the endocardium, and then endocardium and endocardium and intracavitary. If you were to enhance this image, for example, with something that causes a lot of bouncing of ultrasound waves, for example, divinity contrast, you can start to get the principles of LV chamber quantification. So, okay, so we have this ultrasound. We know that the interfaces are going to be the things that are going to brighten up, but how are we making these waves? Well, like everything in life, it comes from Greek. And in this case, we use these special properties of crystals called piezoelectric. Piezo or piezo is pressure, and electricity or electric is electric. And what it does is it basically gives you the understanding that if you bend a certain crystal a certain way, it generates an electrical signal. Similarly, if you stimulate that crystal with an electrical signal, it will bend, or in many ways flick, to create a certain type of ultrasound wave. And so that's how our ultrasound beams are created, with piezoelectric crystals. And importantly, that's why we don't like them to be knocked around and dragged behind the ultrasound machines, because those crystals are very sensitive. And if you start breaking those crystals, you're going to have less and less ability to make good ultrasound waves with that. So what does the ultrasound probe actually do? Well, we've kind of built the principles of what a wave is. We know the principles of how that can help us with spatial resolution. And we know that there's going to use piezoelectric crystals, but how does it utilize them? Well, it utilizes them in two ways. Firstly, it generates a signal that is fixed. So we know the frequency of that signal, and we, by definition, will know the wavelength of that signal. And then it will create a pulse, and then it will stop and it will listen. And it's going to listen for the reflection of that pulse coming back to it. And in fact, if you see this principle on the right here, where you have an ultrasound beam, so there's a formula that we're going to talk about formulas, but we're going to use this formula here. So it says D equals CT divided by 2. C is the speed of light, the speed of sound, which we said was 1,540 meters per second. And in fact, you can extrapolate the distance that this ultrasound wave travels by knowing the speed of sound in the median that it is, as well as knowing the amount of time it takes to get back to us. And that is the principle of how the ultrasound beam figures out where things are. It sends a pulse, then it sends a pulse, then it listens for that pulse, and in that listening time, it's going to figure out how much time it took to get back to it. And if you know all the other parameters, which the machine does know all the other parameters, it can extrapolate the distance and then put a picture on a screen telling you how far it is based on the probe. You're still with me? Good. So lastly, we're going to talk a little bit about the phased array. So this is what the actual probe is like on an ultrasound machine. And so, to kind of recap in a very quick way, we have ultrasound waves that are created. They're created by piezoelectric crystals that kind of pulse. So they give a signal and then they listen to the signal. And in fact, what they can do is they can create a gradation of waves, okay? A phase of waves, which means in different points in time. And then this can create an array of pictures. So on the left, what you're seeing is there's alternate activation of certain ultrasound waves through the piezoelectric crystals. So in the beam 1, you have the most left piezoelectric crystal creating a wave, and then the next one, and then the next one, and then the next one. And it creates a shell of ultrasound waves that kind of have a little bit of a curve to them. So we're exploiting time and the relative consistency of the ultrasound waves to create a fan of images, okay? And that's how we use our ultrasounds to figure out what's going on here. So this picture on the right of your screen is showing you a heart, and you can see that the fan is going to be created by this array that's phased differently in time. Okay, that's what a phased array is. Our probes are usually about 2 to 4 megahertz, all right? And that's what we usually use. So usually I think it's customarily 3 megahertz for the adult probes, but you can make changes and there's gonna be subtle stuff between different companies, etc. So let's do some math. I know everyone's really excited for that. I certainly am. Like we said, 3 megahertz phased array. And if we use the formula that we figured out in the beginning, that inverse relationship between wavelength and frequency, we can find that the wavelength of our machine, when we use the 3 megahertz probe, is 0.513 millimeters. And in fact, that is important because it'll dictate, like we said, our axial resolution. So we can see things that are about 0.5 millimeter. And then if you take away the radius, if you actually use the calculation on the entire size of the phased array, which with radius of about 5 millimeters, we can understand that the near depth field, so the things we can see close to us, are about 48 millimeters, all right? And so some of you out there who are probably still listening will say, well, then why do I care about this number? But I think the important thing is to understand that that's the distance in which our ultrasound beams are the most effective. So when you put someone on your left lateral decubitus position to get the heart closer to the skin, we're bringing the heart into that field of 4.8 centimeters to get a better near field spatial resolution. And in fact, it's also helpful for patients who are in our ICUs. So if you're intubated or you have a large chest or adipose tissue or ventilated, that distance is going to change because you're going to have more stuff in the way. And in many ways, it's going to impact how we're going to be able to see our near field. So there is practical representations to this. All right, intermezzo one. That was a lot, I understand. For those of you who are still listening, congratulations. 90% of people by this point have started online shopping, so I'm okay with that. But we have covered a lot. So we've covered the basics of the wave, we've covered the properties of waves, and we figured out how the ultrasound generates the pulses. So then we get to the more interesting stuff. Did you guys hear that? I don't think it did, but this guy heard it. Does anyone know who this is? I'm gonna wait 10 seconds. Not a single person. Well, this is Christian Andreas Doppler, all right? And he is an absolute beast of a human being. What he figured out at the ripe old age of 38, 1 year after he was hired to work at the Prague Polytechnic, he gave a lecture, and it was called On the Colored Light of the Binary Stars and Some Other Stars of the Heavens. That's the actual title from his original paper. And what he postulated and subsequently proved was that the observed frequency of a wave depends on the relative speed both of the source of the wave and the observer, all right? It's not just one or the other, it's both. When it comes to stars, and we talk about celestial bodies, it's talking about the differences between light coming to objects like us, which are relatively fixed as compared to the distance of stars, but the stars themselves are moving amongst themselves. So what he described was this binary star system, which we see in the middle here, which means that there are 2 stars. And you can see that both of those stars have a slightly different color. It's because those binary stars are in fact rotating around each other, and one of them is moving away from us and one of them is moving towards us. And that moving away and towards changes the frequency of the light waves that are coming to us, and that by definition is hitting our eyes differently as different colors. For those of you who are star enthusiasts, this is the Albireo binary star system. It's part of the Cygnus constellation, and in medieval Arabic, it's described as the hen's beak, which I thought was kind of cool. So then how is that in red? So, obviously we're not ultrasounded stars. That would be really cool, but I don't know if that would yield any useful information clinically. But we are doing it in the heart, and we are doing it in the cardiovascular system. So on the cartoon on the left, you can see that there is a ultrasound beam that is being sent by the ultrasound transducer, okay, at a specific wavelength and frequency. And as this erythrocyte is moving towards the ultrasound probe, it actually bounces back to this ultrasound wave, but at a higher frequency than what it is. And so we can actually use those shifts to figure out the velocity of the stuff that's moving, all right? Similarly, as the erythrocyte is moving away from the probe, the ultrasound reflected beam is going to have a lower frequency and a higher wavelength, and it's also going to be giving us useful information about where the speed of the erythrocytes, which is really what we're trying to figure out, right? The speed. And so the formula on the right is from the original paper by Doppler himself. And, you know, there are a lot of constants in there, but there's kind of two important points. The first one is this cosine theta. And this is what we talk about always when we're talking about valvular lesions and other kind of continuous wave Doppler, is that we want to make sure that we are at as parallel, not perpendicular like I wrote there like an idiot, as parallel to whatever we're measuring as possible. Because if there's the angle between what we're measuring and our ultrasound probe is 0, then the cosine of 0 is 1, and that then becomes a real formula that you can use. If you are perpendicular to it, okay, so perpendicular is worst, all right, not best, perpendicular is worst, but cosine of 90, so if you're exactly 90 degrees, is 0. And for those mathematic enthusiasts out there, if you ever divide by 0 in mathematics, you're in for a bad time. So that's usually why we like to have things as parallel as possible. So now we've talked a little bit about how we can extrapolate speed of erythrocytes or speed of anything by exploiting the understanding that the reflected waves will have a predictable change in both their frequency and their wavelength. Now we have to talk about how blood moves within the body. And in fact, it moves weirdly. So this is not a good representation of blood, but it is an interesting representation of how things move in a tube, all right? And in many ways, our examples are always a cylinder or a column of blood. So on the left, you have this turbulent flow, which you can see the various eddies and currents within it that are kind of mosaically going through it. Then you have a uniform perturbation, all right? In this particular example, it's a fan. But what we can see is that downstream, this perturbation is going to start to become more laminar. So the thing that you're looking at on the right is laminar flow. And the important bit here is that if you look dead center of this stream, it's going, the fluid or whatever's in there is going much, much faster than what's going on the side or close to the edge. And that's a very good characteristic of laminar flow. Let's see here. Oh, sorry, I clicked something. So let's keep that in mind and understand that blood, much like NASCAR drivers, does not like to go around corners. It likes to go straight, and it definitely does not like to take turns, all right? So another pictorial representation of laminar flow is this. And what you can see is that there's gradations or kind of, concentric circles of flow that are going through this. And the middle is going to have the highest flow. Laminar flow is going to have the highest flow right in the center, and it's going to get slower and slower and slower on as we get closer to the edge. And importantly, when a flow goes through a tighter orifice, through the through the Navier-Stokes equations and other fluid mechanics, the actual flow slows down and becomes more uniform. And in fact, if this becomes too slow, what you get is something called boundary layers, and those boundary layers are going to be the thing that are going to cause you turbulence. But in general, we're not going to get into that. We're going to understand that there's going to be a gradation of flow, and then there's going to be a stenosis, which is going to even out the flow, which is an important characteristic. And then further down, it's going to become more laminar again, like we saw before. So in this larger pictorial representation, you can understand that there's going to be flow going through the orifice. There's going to be some pre-stenotic acceleration, which is something that we see on our Doppler, which gives us an understanding of what we're seeing. And in fact, we can exploit those pre-stenotic acceleration to describe the size of the regurgitated orifice. And then all of the flow is going to kind of go through in a very similar speed, and it's going to have this nice little waist called the vena contracta. And the vena contracta is going to be the narrowest portion of this regurgitant flow. Another important point is that the orifice of the stenosis is here, but the vena contracta's most narrow point is further down from the stenosis, right? And that's another important characteristic when we're talking about effective regurgitant orifice area. It may not necessarily be the same size as the actual orifice itself. However, we can make some estimations on that as well. And importantly, when we have that, is that we lose laminar flow next to it. So like we saw in the previous example, when we have this perturbation, it became much, much more turbulent. Now, later on down this tube, we're going to have reinstatement of laminar flow, and that has to do with both the law of conservation of kinetic energy and potential energy. And so, again, you know, those who are astute observers will say, well, why the hell do I care? And so that's why we talk about this spectral profile, all right? So if you ultrasound a laminar flow, like we have in the heart, for example, using this pulse wave through this aortic valve, you get this gradation of flow. And in fact, what you're seeing is laminar flow. So the highest velocity is right at the top here, and that's this V max, this middle bit. And then all of the other things you're seeing are going to be different speeds. Now, it's a little bit fictitious because the Doppler profile is actually done through time, right? So this is not the same instantaneous moment of all the laminar flow, but it is a representation that there is different types of flow over time, which is, again, something we explore regularly. All right, intermission number 2. That's a lot of information, so I apologize. And now let's go to some more kind of interesting stuff. So the tale of aortic stenosis and how I learned to love it. So we talked a lot about how we make waves. We talked a lot about how blood doesn't like to go around corners or go through any tight holes. And then we also understand that we can put all of this together to give us an understanding of aortic stenosis. So on the left, the first bit of cardiology that I guess you guys will see is the graphical representation of an aortic valve. There are 3 cusps. And in fact, we know that from population data and from Braunwald and from several other studies that have come subsequently from that there is a relationship between the flow and the gradient and survival. So on the right, you can see a table, and that table is looking at both the survival of patients who have so NFHG is normal flow high gradient, and the very bottom is low flow, low gradient. And you can see that the low flow, low gradient people did worse. So they survived less. And in fact, with medical management, it doesn't really change very much. So that's why in many ways we talk about aortic stenosis as a surgical problem, because it really is. There is no medical therapy that's going to make this much better. And in fact, the only way to make things better is to bring them back to their natural history, which means fix the stenosis and have a normal aortic valve orifice. Normal aortic valve area, for those who are interested, is about 3 to 4 centimeters squared. It really depends on body size. It depends a lot more on height, and in some ways on weight, but it's about 3 to 4. So let's talk a little bit about the mathematical pathophysiology of what happens to the heart with aortic stenosis. Okay, so the issue with aortic stenosis is that you have a fixed obstruction. Okay, the obstruction is at the outflow of right at the end of the LVOT towards the rest of the body. And we can use something called Laplace's law to understand a relationship between wall stress and the thickness of the left ventricle. And the important thing about wall stress is that is wall stress, not the stenosis itself, but stress on the wall is what we define as afterload. Okay, we can understand conceptually that afterload sounds like there's going to be a pressure problem, right? You're trying to shoot blood through a tiny little orifice, but what that's doing is that tiny little orifice is actually causing a higher wall stress, and as such, a higher afterload. And in fact, in Laplace's law, we can see that wall stress is inversely related to thickness of the LV. So the higher the stress, and you're going to have a change in your thickness to overcome this wall stress, okay? So if the heart wants to overcome this afterload, all right, if it's overwhelmed by wall stress and it wants to do something to make that wall stress less, okay, what it's going to do, and what it really has the only ability to do, is change the thickness of the LV. So in fact, this is the mathematical reason why patients who have a fixed obstruction are now experiencing a hypertrophy of their muscle, because that's increasing the thickness of the LV and decreasing the wall stress, which is always what the heart is trying to do. It can't really fix the radius of the LV, although an argument can be made that hypertrophy changes the radius of the dynamics of the LV, and it really can't fix the transmural pressure, which is much harder to do. So it ends up increasing the thickness, and that's why we get LVH with aortic stenosis. Okay, but the concept here that's important is that afterload is wall stress, Wall stress is inversely related to thickness. And if the heart tries to reduce wall stress, it has to increase the transmural, the LV thickness. So we're going to go to my next favorite mathematician now. We're going to go to the big man from Basel. All right, this is Bernoulli on the right with his basketball, which is actually just a world. And what he expressed in many, different mathematical ways is that there is a law of conservation of energy. So if you have a stenosis, like we see in this pictorial representation, then the kinetic and potential energy before the stenosis and the kinetic and potential energy after the stenosis needs to be the same, all right? That's the law of conservation of energy. It cannot be created or destroyed. It is what it is. And we can exploit that to figure out a formula to understand the representation between velocity and pressure, all right? Because kinetic energy is in many ways related to velocity, and potential energy is in many ways connected to pressure. So K1 plus P1 equals K2 P2. We know that K is going to be a constant multiplied by the speed squared. So that's just how kinetic energy is extrapolated. The density times 0.5 roughly comes out to about 4. So you have K is equal to 4B squared. Now you substitute that back in and you solve for P1 and P2. And you get this delta P, or the change in pressure, is 4 times the difference between the velocities squared. The important bit is that when you have someone who has a significant stenosis, okay, like aortic stenosis, the V2 is going to be much, much bigger than the V1. And in many ways, you're going to be able to remove that V1 component because it's not as important. It's negligible compared to V2. And as such, you can make a simplification of the change in pressure is 4V squared. I know, it's just mind-blowing, right? Math, physics, everything works. So echocardiographic evaluation. So this is straight from this. This is straight out of the guidelines. This is what we define as mild, moderate, and severe aortic stenosis. For those of you who are taking the Royal College examination at some point, you have to remember that there is a calcium score that can be used to make the diagnosis of severe aortic stenosis, and those are the numbers there. Otherwise, those of you who are not interested in the Royal College will understand that there's going to be mostly the use of both the aortic valve area and the mean gradient to figure out the severity of the stenosis. And, peak velocity goes by the wayside, not because it's not useful, but because we understand that there's a relationship now between velocity and mean pressure. We can be more accurate in describing our mean pressures because they're an integral over time. So this is what it looks like when you do, this is real life, when you look through a CW through the aortic valve and you can see this large Doppler spectral profile. It's going all the way out to roughly about 4 meters per second. So we're going to call it 4. We're going to use our formula that the pressure is going to equal to 4V squared, and we'll find that the peak pressure in this particular instance is 64 millimeters of mercury. Now, those who were listening and saw the previous table will understand that peak pressure is entirely useless to us. But what we can use is we can use some mathematical equations and a little bit of computer magic to understand the area underneath this curve, all right? And the area underneath the curve of this aortic stenosis is also called the velocity time integral, and we can use that to figure out what the mean pressure is. And in this particular instance, it will be greater than 40 millimeters of mercury. So then, now we understand that we can figure out what the pressure is, but how, like I said, do we look at the aortic valve area? Well, it turns out that the similar equation that we use from Bernoulli can be reused again with the same mathematical assumptions for the continuity equation. And the continuity equation is saying that for a fixed amount of flow, all right, within something, in this case, it's the heart, you're going to still have a law of conservation of energy. But we're going to make a representation of the differences between the velocity and the aortic valve area, all right? And in this case, you have A1, which is the area before the stenosis, and in this particular instance, the left ventricular outflow tract, and the V1, which is the velocity of blood through that LVOT. And in fact, that is usually represented as the time velocity integral, or the VTI through the LVOT, okay? And then that is going to be equal to the area and the velocity of blood that we measure after the stenosis, And in this particular instance, after the stenosis is after our aortic stenosis. So using those formulas, we can then estimate what the aortic valve area is, knowing the VTI of both the LVOT and the VTI of the aortic valve and the area of the LVOT. And that's important, all right, is that the area of the LVOT is going to be the largest amount or largest point of error. Because what happens is that the area of the LVOT is going to be expressed as 2 pi r squared. And pi r squared means that you're going to be squaring any errors that you have in the LVOT. For those of you who are going to be echocardiographers or are thinking of doing this or just working in our lab, that's why we're very meticulous to make sure that the LVOT areas are the same for the same patient over time if we're following a stenotic lesion. There's no reason for the LVOT to be 2 centimeters one day and 2.2 centimeters one day unless you are still growing, which most adults aren't. And so that's an important caveat, that the major source of error is the LVOT size. So we've talked a little bit about how we can estimate flow and pressure, velocity and pressure. We've explained how we can do the estimate the area based on knowing the velocities, which we can use the principles of Doppler to figure out what the velocities and the time velocity intervals are. And so now we have to get to the last bit, which is a little bit more higher level, all right? And it's talking a little bit about something called pressure recovery. And to go back a little bit, we have to understand that before echo was the way to evaluate these things, and still is, most of the ways we were trying to express both pressure, area, etc., was by cath. And so in the early days of echocardiography, they tried to correlate the echo findings and the cath findings, and they found consistently in certain instances, in the size of the aorta and the stenosis of the aortic valve, that the echocardiographic findings were often higher than those that were measured in a small subset of patients on angiogram. So the question is, why is that, right? Well, the big man from Basel is back at it again, and we remember the formula about the 4V squared. But the more important concept here, and the thing that we have to understand, is that there is a continuum that happens between when the blood goes through the LVOT and the aortic valve and into the aorta. And what happens is that there's the pressure. So if you look at this line, the top line here, the pictorial representation, so the pressure before the stenosis, okay, is going to be higher than the pressure at the stenosis. The reason that that happens is because the velocity is now increasing. So as the velocity of flow increases, you know, P equals 4V squared, if the V starts to increase, then the pressure starts to decrease. And that is, in fact, many of the ways in which we exploit the principles of flight. We understand that if we change the flow of air above or below a wing, we can exploit that and cause a lower pressure system under the wing, over the wing, which generates lift. And so in this case, we have a slowing of pressure or lowering of pressure, but an increase in velocity when we are accelerating towards the stenosis. And then we have our vena contracta, which is going to be a little bit longer than the actual orifice. So it's not going to be here. It's going to be a little bit closer to P3, V3. And then as this column of blood is now trying to shoot itself into another bigger column of blood, what eventually happens is that the speed starts to decrease and the pressure increases. And so the important bit here is that when we are putting our catheters, which are sitting very close to this aortic valve, what we're going to be seeing is a higher velocity, a higher V3 the closer we are to the valve than we are further away from the valve. And in fact, that's kind of a principle that we see very frequently between the discrepancies of ultrasound. So after the stenosis, the pressure starts to rise, and this change of kinetic energy of velocity becomes potential energy pressure, and the pressure then recovers. It's called pressure recovery. Now, the reason why that's important for us is that when we use the continuous wave Doppler, so we look through the entirety of those velocities, we're not going to be able to distinguish V3 and V4. All the CW is going to tell us is that the highest velocity is going to be V3. And so we are going to find a higher velocity and ergo use this mathematical formula to find a higher pressure than what you will actually find if the catheter is sitting close to that aortic valve. And that is the principles of pressure recovery, that our Doppler is only looking for peak pressure, highest velocities with the CW, but that doesn't necessarily constitute the milieu of pressures and velocities that are within that aortic valve. A little bit subtler concept, but it really just breaks down into the law of conservation of mass, right, and energy. So as such, the higher pressures overestimating, higher velocities overestimate the pressures, et cetera, et cetera. Oh, okay, so that was a lot of information, I guess. And I'm sorry for the snooze that many of you probably would have wanted to do instead of being in this talk or listening to this talk. But I think we got through a lot of stuff, okay? So we learned how to make ultrasound beams. We learned how we can use them to create pretty pictures of the heart. And we learned how we can exploit physics to estimate flow and pressure, and how we can estimate the severity of our commonest disease that we find, which is the aortic stenosis. So I think we covered a pretty good amount of stuff there. So I want to thank everyone for listening. That's my daughter on the left there telling me to come into the splash pad with her. I am happy to take any questions that anyone has, and thank you for listening.